another very interesting online interviews here at Top Doctors, where we interview one of our leading UK consultants. And today I'm delighted to say we're joined by leading oncologist, Mr. Simon Brewster, leading urologist, consultant urologist based in Oxford. Mr. Brewster, thank you so much for joining me this afternoon. How are you?
It's a pleasure, Connor, and I'm very well, thank you.
Excellent.
Nice not to be wearing a mask.
Absolutely. Now you're free to interact without the difficulty of the mask, you know.
Yes.
So, well, I'm delighted to welcome you, Mr. Brewster, and we're very happy here at Top Doctors to commemorate and mark this month's Men's Health Awareness Month, Movember 2021.
Sure.
And to mark this month, we're happy to talk to you, Mr. Brewster, and get your expert insight with regards to prostate cancer. And before we start with the questions, Mr. Brewster, if you'd like to maybe introduce yourself to our audience, maybe explaining about your specific field.
Yes, well, thank you. I'm a consultant urologist, and I've been working in Oxford, both NHS and privately, since 1998, leading on the development of the prostate cancer service, and also treating a lot of men with benign prostate problems. So really, I might be known as a prostatologist rather than a urologist.
Absolutely.
But, yeah.
Fantastic, Mr. Brewster. Well, I suppose, of course, it is a condition that affects millions of men worldwide, prostate cancer. And how exactly is prostate cancer diagnosed? And what specific tests and assessments are required for the diagnosis?
Well, prostate cancer is commonly present without any symptoms. So sometimes people don't know they've got it unless they were to have a blood test called PSA, which stands for prostate specific antigen. And this is a blood test that can be requested through general practitioner primary care. The general practitioners will tend to do the blood test also for men who go to them complaining of urinary symptoms like slow flow, urgency to get to a toilet quickly, and maybe getting up at night, those sort of common symptoms. And often if they do the blood test and the blood test is borderline or abnormal, they might be offered an examination of the prostate, which has to be done through the back passage. So it's called a digital rectal examination. And sometimes that might show a nodule on the prostate. Other times it might be just smooth and enlarged, which is quite common. So beyond that, the next usual investigation, if the PSA blood test or the rectal examination are abnormal, would be to go for an MRI scan of the prostate, which gives good images and may show a suspicious region of interest, or it may not. If it does, then usually the best way to further investigate a suspicious region on an MRI scan is to perform a biopsy. And this is where some actual tissue is removed from the prostate using a fine needle under ultrasound guidance. And this is sent to the pathologist who looks at it under the microscope. And this is the only way that prostate cancer can be diagnosed for certainty or ruled out. So the biopsy, if it does show prostate cancer, can also give further information, such as the amount of cancer in the biopsy sample and the grading of the cancer, which means whether it looks aggressive or non-aggressive. And an awful lot of prostate cancer is non-aggressive, so that's very helpful information.
Absolutely, the non-aggressive type for patients to know. And what would the main difference be between the progressive and non-progressive type there, Mr. Brewster?
Well, the pathologist will look and he or she will notice how the cancer cells are behaving in relation to the surrounding tissue, and the more aggressive types will appear to be more invasive into the surrounding normal tissue. The biopsy is usually taken under a local anaesthetic, and antibiotics are given to reduce the risk of an infection. Patients on blood thinning medications, anticoagulants, usually have to temporarily stop taking these because there is a risk of bleeding after any minor surgical procedure like a biopsy of the prostate.
Absolutely. Fantastic insight there, Mr. Brewster. And I suppose for any patients who might be worried about potential symptoms of prostate cancer, when would you recommend that they get checked out?
So I mentioned that there are some common urinary symptoms that affect middle-aged and older men, such as a slow flow and waiting to get started and perhaps dribbling on afterwards, and also getting up a lot at night and needing to get to a toilet very quickly for fear of wetting oneself. These symptoms are often associated with a benign prostate trouble, but can be associated with prostate cancer as well. And there are some other causes of those symptoms. So usually what I would suggest is that any man who has noticed these symptoms developing and causing some bother should ask a GP's advice about whether to get the PSA blood test and a rectal examination of the prostate taken. And also a urine should be tested just to check for infection, which is another common cause of those symptoms.
Absolutely. So you would definitely recommend for patients to definitely, if they notice some symptoms, to definitely get checked out, because, well, an early diagnosis is definitely better than a late diagnosis.
Well, yes, prostate cancer is sometimes very non-aggressive, and in fact, more than 50% of men over the age of 65 will have a tiny spot of prostate cancer, and it will probably do them no harm. But there are a few prostate cancers that can grow quite rapidly and spread, and that is when they can become life-threatening. So an early diagnosis is always going to be better when curative treatment can be offered if the cancer is contained or very nearly contained inside the prostate rather than having spread away.
Absolutely. And well, then our following question then, Mr. Brewster, what does an effective surveillance of prostate cancer entail, and how exactly are patients monitored?
Yeah, so if a patient goes through the investigation pathway and has a biopsy which shows a small non-aggressive looking prostate cancer, then it can be safely monitored and may never need any treatment. The way we monitor it is by using the PSA test every 3 to 6 months, and at least a once a year examination and an MRI scan every 1 or 2 years to follow and check that the disease is not growing. Occasionally, we do perform repeat biopsies also to monitor or surveillance the disease. But there is an advantage to surveillance, and that is that most prostate cancer treatments do cause some side effects, both on the urinary tract and also on sexual function, and sometimes on bowel function. So avoidance of those treatments can be good for quality of life. And so active surveillance of prostate cancer is quite popular for safely monitoring small non-aggressive prostate cancers.
Excellent. And then another one then, Mr. Brewster, how is treatment for prostate cancer decided between the patient and urologist when they meet together to discuss the options? What should be taken into consideration when making this decision? It is a very important one.
Right. It's quite a complex discussion sometimes. If the disease is small and non-aggressive, then it's often quite an easy decision to recommend active surveillance. However, if the disease is larger and slightly more aggressive, then the options to treat it while it's confined to the prostate would commonly include a surgical removal of the prostate, which is called a radical prostatectomy, or some form of radiotherapy to kill the cancer cells inside the prostate and hopefully cure the patient. And the choice between surgery and radiotherapy, whether it is external beam radiotherapy or implanted radiotherapy with some radio emitting seeds, which is called brachytherapy. This is quite a complicated discussion and may include both a surgeon and a radiation oncologist or clinical oncologist. So each of these specialists may see the patient and discuss the advantages and disadvantages of those treatments. If the cancer is small and on one side of the prostate only, there is also the option of what we call focal therapy, which is treating just half of the prostate by some means to try and kill the cancer. Now, this is a relatively new strategy, and there are a number of minimally invasive options being researched at the moment, including options like cryotherapy, which freezes part of the prostate, or high intensity focused ultrasound, which heats up part of the prostate. There are other options under investigation as well, such as photodynamic therapy using an injected drug and a laser, or electroporation, which means effectively blowing the cells apart with electric current, which is very confined between two implanted electrodes within the prostate. So these are some quite exciting minimally invasive options for treating just a small part of a cancerous prostate. But the mainstream of prostate cancer treatment remains radical prostatectomy and radiotherapy, and these two treatments have got good long-term outcomes, albeit with some risk of side effects.
Fantastic, Mr. Brewster, and very, very good to know that these new, very effective, modernized treatments are available for patients with prostate cancer. And do you see that they're becoming more and more popular with patients?
Well, patients would prefer to have treatment with a low risk of side effects. So it is attractive that to avoid major surgery or large doses of radiotherapy, although these are proven to be effective, they can cause upset to bowel function, sexual function, and urinary function in some cases. So, so the focal therapy treatments, which are now being looked at, are popular, but as yet don't have a long proven track record of success in terms of getting rid of the disease.
Okay, excellent. And well, very exciting for the future indeed, as you mentioned, for patients who will be worried about what treatment is best for them. But it's great to know that there are many options currently being tested as well for the future. It's fantastic.
Absolutely.
And then our next question then, Mr. Brewster. How might prostate cancer treatment affect a patient's daily life and daily activities? You mentioned that some of the treatment does have some side effects, unfortunately, but how would it really manifest in their daily lives?
Well, for a start, prostate trouble can cause patients inconvenience, whether it is benign enlargement or prostate cancer, inconvenience in terms of being up at night and therefore being quite tired, and also needing to be aware of where the next toilet is likely to be should they need it quickly. So without treatment, the prostate can cause this type of inconvenience. Following treatment, then ideally, at least the cancer has been destroyed or removed, and the patient then may equally have to put up with some bladder symptoms, and possibly also they may find that they can't achieve a good erection or ejaculate normal fluid at the time of an orgasm. So that can cause some upset to some patients, and it may be that they will need to use oral treatments such as Viagra or other more involved means to enable a good erection to be sustained. And then bowel function can be upset by radiotherapy, not so much radical prostatectomy, and so patients can sometimes pass more urgent bowel motions and or some blood with their bowel motions. Now, more recently, we've been injecting a gel behind the prostate, between the prostate and the bowel wall, which is normally very close together. We've recently been injecting a gel to create a space between the prostate and the bowel wall, and this is proven to reduce the risk of bowel trouble following prostate radiotherapy.
Excellent. And I suppose you might, in your experience, you see that it does depend maybe on each individual patient with how the treatments can actually affect them in their daily lives.
Yes, very much so. Some patients sail through treatment, such as radical prostatectomies or radiotherapy, with barely any side effects, whereas others can experience some side effect, and very occasionally someone gets a life-changing side effect, such as really troublesome incontinence requiring surgery to put it right, or a bowel injury that's very troublesome.
Absolutely, Mr. Brewster. And well, our final question for you today then, with regards to prostate cancer, what can the patient expect in terms of making progress during their treatment process? How often will they need to have a thorough checkup?
Well, whatever treatment is done, we usually like to follow patients up with PSA testing about every 6 months. And depending on whether there's been any suggestion of spread of disease at the time of the treatment, we may wish to perform further scans to assess whether disease is progressing away from the prostate or where the prostate was. So there's a very good new technology called a PET scan using a radio-labeled isotope that that is fixed to an antibody that sticks to the surface of prostate cells, what's called prostate specific membrane antigen, or PSMA. And this type of scan is becoming more and more widely used in the UK for detecting very small volumes of prostate cancer that may have spread away from the gland. And it's a mixture of the isotope lighting up and a CT scan, cross-sectional imaging, that can show exactly where this isotope is emitting relative to which part of the patient's body. So that's very good, sensitive new technology that's become available in the last couple of years.
Absolutely, Mr. Brewster. Well, it is very, I suppose, very reassuring to patients who might be diagnosed with this devastating illness to actually know that in the future there will be many, many treatments, very effective treatment options available for them. So very reassuring to hear that from such an expert in this area. Of course, consultant urologist, Mr. Simon Brewster, thank you so much for joining us. It's been a pleasure, Mr. Brewster.
That's
for
a pleasure.
anybody out there, fantastic. And for anybody out there who would like to find out more information with regards to Mr. Brewster's areas of expertise, you can head on over and check out his Top Doctors profile on www.topdoctors.co.uk. Thank you, Mr. Brewster, for joining us once again.
Thank you very much, Connor.